Hello, everyone. This is the group debate project for SPCE 619 at Ball State University. Our debate will be focused on the following situation. Individuals with autism or other developmental disabilities who engage in severe aggressive behavior in SIB can pose significant threats to themselves, peers, and staff, teachers, and parents who work with them. The Ethical Code promotes the use of least restrictive procedures. However, those providing services to individuals with severe problem behavior may consider the use of restraints and/or seclusion, stating these are necessary to prevent severe self-harm or harm to others. Consider the ethical code, the literature, and create debate that addresses the different sides. Is the use of restraints and seclusion ethical? What role should a behavior analyst play in interventions involving restraint and seclusion? And what does the literature and ethical code indicate? For this debate, we will be referring to the Civil Rights Data Collection, or CRDC's definitions of physical restraint, mechanical restraint, and seclusion. Physical restraint is a person or personal restriction that immobilizes or reduces the ability of moving the torso, arms, legs, or head freely, and it does not include a physical escort. A mechanical restraint is defined as the use of any device or equipment to restrict a person's freedom of movement. And seclusion is the involuntary confinement of a student alone in a room or area from which the person is physically prevented from leaving. We will begin with opening statements from each side, followed by an evidence-based portion, rebuttal, and closing remarks. Each team will have 4 minutes to complete each section. Arguing for the pro team will be Lisette Moreno and Claire Calvert.
Hi everyone, my name is Lisette Moreno. I am currently a registered behavior technician. I provide both in-home and in-clinic ABA therapy. I have been in the field for approximately 3.5 years, and I am from the state of Illinois, and this is my first semester at Ball State University.
Hi everyone, my name is Claire Calvert. I'm arguing for the pro side for the debate. This is my second semester at Ball State University. I've been teaching special education for 6 years in the state of Maryland. I teach in a preschool autism program that utilizes the ABA methodology in my program.
All right, and the con team will be argued by Katie Dirks and Amanda Moore.
Hi, my name is Katie Dirks, and I'm a supervisor at an autism center, and I have been in the field for 2 years. I also have 2 semesters left until I graduate, and I will be on the con side for using physical restraints on individuals.
Hi, my name is Amanda Moore, and this is my second semester at Ball State University. I currently am a program assistant at a center that provides ABA services to children with autism, and I have worked there for almost 4 years, and I will be on the con side of the debate.
All right, and my name is Danielle Rowland, and I will be moderating the debate. I'm from Kalamazoo, Michigan. I'm in my 5th semester here at Ball State and currently work as a behavior therapist in an autism ABA center. So we will begin with the opening statements, and the pro team will start us off. You have 4 minutes.
So the first topic that I would like to, oh, I'm so sorry.
So thank you, Danielle. To begin with, one of the core ethical principles of ABA is benefiting others. This principle ensures that the main focus be for the benefit of the client. The same principle also targets the importance of benefiting others, such as teachers, peers, family, and community members. This core principle measures short-term negatives versus a long-term benefits. Several people can be treated without the use of restraints and seclusions. However, they may be necessary in some cases. Seclusions are sometimes necessary to help protect the individual as well as others around him or her. It is important to note that seclusions should only be implemented by professionals and them using their best interest for the client. Restraints are typically used to reduce frequency of severe problem behaviors. Restraints should only be implemented by trained professionals, and both restraints and seclusion practices vary by state, district, and classroom. There are also several different types of restraints varying in level of aversiveness. For example, the prone restraint means that the child is laid in a face-down position. And a mechanical restraint includes straps, cuffs, tape, and other devices to prevent the movement and or sense perception. And it often means that the client or the individual is pinned down in some form of platform. So there are also several other kinds of types of restraints. For example, there's the supine restraint, there's an actual physical restraint, which Danielle mentioned briefly in the introduction, and there are also chemical restraints. Chemical restraints typically rely on medication to actually dull an individual's ability to move. So with that being said, you should always use the lowest to highest level of intrusiveness for a client. So we should always start with a prone restraint before thinking about going into a physical restraint or a mechanical restraint, and finally a chemical restraint. Although restraints can be used, a treatment plan should contain reinforcement-based procedures. So although restraints are used as a final resort for an intervention plan, there should still be some form of positive reinforcement involved in the child's behavior plan for trauma purposes. Finally, restraints should be considered only when less intrusive interventions have been attempted and failed, or are otherwise determined to be insufficient given adequate empirical documentation to prove this point. And this was written by Vollmer et al. Of 2011. And that concludes my part. I will pass it on to Danielle.
Okay, and now we will hear the opening statements by the con team.
I'll be first starting off with the physical restraints from the article Use of Restraints, Seclusions, and Aversive Procedures on Students with Disabilities by Barbara Trader. Physical restraints is defined as a personal restriction that immobilizes or reduces the ability of an individual to move his or her arms, legs, or head freely. This does not include physical escort. When a restraint occurs, it does a lot more than holding the client from harming themselves and others. It can cause serious injuries to both the client and the staff. In Visual 1, you will see that this shows a summary of restraints and injuries data from a residential facility in southeastern Pennsylvania. Overall, this table shows that emergency use of restraints resulted in higher injury levels. All personal restraints injured 168 individuals. As you can see in my second visual, this table shows you the different types of restraints related injuries in the same study. Scratch and abrasion and cut with no sutures were the top, resulting in a total of 240 different accounts of injuries. There has been many studies determining what type of restraint is the best to use for aggressive individuals with autism spectrum disorder, but each outcome of the restraints show that it causes injuries, trauma, and it's an easy way out of behavior for the workers to just put these poor individuals in a hold that end up causing more injuries. Not only do restraints cause some serious consequences, it also fails to provide the students the support that will help improve their educational environment, as well as teach them pro-social behavior or replacement behavior. We need to be teaching our kids new coping strategies and self-management skills to prevent the strain it has on the parents, the staff, and the client involved in the restraint. That concludes my con statement.
All right, that completes our opening statements. We will now move on to the evidence-based portion of the debate. Each team will have another 4 minutes to prove their claims, and we will start with the pro team again.
The first topic that I would like to cover are restraints in relation to the right to effective treatment. The BACP Code of Ethics states in Code 2.09 that clients have the right to effective treatment based on research literature and adapted to the individual client. Behavior analysts have the obligation to advocate for the client and educate the client about scientifically supported and most effective treatment. Effective treatment procedures have been validated as having both long-term and short-term effects for the client and society. Now, considering this statement by the BACP Code of Ethics, we must conclude that if a restraint is determined to be the least restrictive measure to treat an individual's behavior, then the individual has the right to this treatment of restraint. And furthermore, by denying them of this restraint as an effective treatment, we would be acting unethically in accordance to the BACB Code of Ethics. According to the same Vollmer et al. Article in 2011, a regulation that prohibits the treatment that includes the necessary use of restraint violates the individual's rights to effective treatment. So we must consider our clients' rights when considering the use of restraint. The next topic that I would like to cover considering restraints are the function of the restraint. So what function does the restraint serve? So the restraints can serve the function of preventing dangerous behavior such as self-injury or aggression. It can protect both the individual and others. So it can protect the individual in the instance of self-injurious behaviors, as well as others in the instance of aggressive behaviors. It can also be used for therapeutic functions, which are also discussed in the Vollmer 2011 article. Restraints and seclusion can also be used to decrease frequency of behavior as well as intensity of behavior. So not only can they decrease the amount of instances that the behavior occurs, it can also decrease the intensity or how severe that behavior that is occurring. Now I would like to discuss the evidence that I have to support this article, which I'll be using the visuals that I have. The first visual that I have shows a Des House study that was conducted in 2015. And this shows that self-injurious behaviors, which are represented by the open circles in this data, were severely or significantly decreased once a restraint was implemented. And once the restraint is implemented, it's shown in the darker circles. So the open circles show it without the restraint being implemented and how severe and intensive the self-injurious behaviors are occurring. And then you can see the significant decrease once the restraint is implemented, showing that in conclusion, by implementing a restraint, we can decrease those self-injurious behaviors. The next visual I have is from a Tompowsky article in 1983, in which the baseline of disruptive behaviors shows a significantly high instance of frequency of disruptive behaviors. And then once the treatment was implemented, you can see the dramatic decrease of the behaviors. And at the bottom of that, this visual, you can see that not only did the disruptive behaviors decrease, but the positive behavior or task-oriented behavior significantly increase. And that shows that not only can our restraints have a positive effect by decreasing disruptive and self-injurious behaviors, but they can also subsequently increase other more positive behaviors such as task-oriented behaviors. Now, finally, I would like to discuss how to ensure safety and functionality with restraints, because it is very important to consider safety when we are implementing restraints. Now, in order to do this, we must use an FBA or a functional behavior analysis as a basis to implement restraints. We must use objective data to assess how the restraint is working and if it is decreasing the behaviors in the client. It must be used in the context of a behavior intervention plan, and it must be overseen by a BCBA in order to ensure safety for the client. That concludes my proving statement for restraint.
All right, and now we're going to pass it over to Team Khan for another 4 minutes.
All right. According to Day in his article examining the therapeutic utility of restraints and seclusion with children and youth, the role of theory and research in practice, although using restraint and seclusion may seem like the most positive route to take when trying to maintain disruptive and maladaptive behaviors, they can also be seen as controversial for good reason. Putting an individual into a restraint is an intrusive measure. It is also noted that there is a danger when using restraints and seclusion, and they can become legitimized in a facility and begin to be used without question. Drawings by children where seclusion have been used also depict a lack of warmth. In the article, Restraint Procedures and Challenging Behaviors and Intellectual Disability, an analysis of causative factors by Matson and Boisjoli, restraints can cause injury and physical pain. Professionals in the field are oftentimes reluctant to use restraints because of the physical pain that can be caused and restriction of personal freedom, since restraints involve physically holding a person with the intent of restricting their movement. Unplanned restraints are even more problematic, and the chances of them resulting in injuries to the person engaging in maladaptive behavior are greater. In the 2000 article by Schuerman et al., Professional Practice and Ethical Issues Related to Physical Restraint and Seclusion in Schools, restraints and seclusion were determined to cause physical trauma and continue to remain controversial in the school setting. Students that have been abused or neglected are more susceptible, and although there may not be any physical injuries, the extent and nature of psychological trauma are unclear. There are also several ethical issues related to the use of restraint and seclusion as well, such as the potential for death and injury, failure to use least intrusive measure, being removed from class, and insufficient training, use, and monitoring are some of the ethical issues related. There is the potential for death and injury. Restraint and seclusion have been associated with the child dying as well as adult injuries. The New York Daily News wrote about a 16-year-old boy named Corey Foster who died during a restraint after suffering from cardiac arrest back in 2012. After becoming aggressive, an 8-person prone restraint was administered on Foster, during which he suffered cardiac arrest and ultimately passed away. The Child Welfare League of America estimates that the deaths of between 8 and 10 children each year in the United States is due to restraint. So we have to think of one of the core principles of ABA, which is being just, to provide fair and equitable treatment. Being just states how you would like to be treated and how would you like your children to be treated. Is using restraints that can cause pain and can lead to death being just? And that concludes my previous statement on the content.
All right, and now we will enter the rebuttal portion of the debate, and we will start with protein.
Thank you, Danielle. As I mentioned earlier, restraints should be administered only by trained individuals. So Matt and Raz discuss the comparison between a nurse and a surgeon example, and basically what they said was we would not allow a nurse to perform heart surgery on an individual if they are not qualified to do so. So with that in mind, people who are not trained to provide restraints should not be allowed to do so if they are not properly trained and do not know how to go about implementing them. So the issue then should be proper regulation and peer review to ensure that where very severe problems exist, and by severe problems existing, I am referring to biting off your finger or blinding yourself because you're consistently eye poking yourself, that treatments to curb such problems, including punishment methods, are available and implemented by trained professionals. According to Matin and Taraz, in their view, it was a moral issue. So parents or patient consent, properly qualified professionals, and peer review should be included, with aversive being a last resort, but an available one. These procedures should be implemented only by staff who are fully trained in their use, receive regular in-service training, demonstrate competency using objective measures of performance, and are closely supervised by a BCBA or a similarly trained professional. And this was also written by Volmer in his 2011 article. Amanda, I see that you mentioned that Mattson and Bajoli stated that restraints cause physical restraint, but Mattson in his other article with Taraz also reported that intrusive procedures result in equal rates of positive to negative side effects when compared to positive procedures. So for example, timeout and restraints actually demonstrated positive effect rates equal to a DRO, or differential reinforcement of other behaviors. In addition, Mattson and Taraz also discussed this notion of a parent perspective. So what they discussed was that parents were actually more prone to be supportive of restraints and seclusions if it meant that they were going to protect the lives of their child. So parents are actually willing to use this type of intervention if it means that they are protecting the lives of their kid. First and foremost, the safety of the child is a priority. So as a parent, they want to do everything necessary to keep them alive. In addition, we discussed this notion that restraints and seclusions are very immoral and inhumane. But I ask you, on what criteria? There's no functionally based data to support this, according to Mattson and Taraz in their 1989 article. In other words, it is very subjective. And the negative side effects, in a literature review of 382 articles, there is no data to support that there are actually negative side effects. In fact, 212 articles reported positive side effects and only 16 reported negative side effects. So there was a total of 93% of positive side effects that were reported in this article. And that concludes my statement.
All right, now we will pass it off to the con team with another 4 minutes.
According to Walker and Pinkelman, there are increasing efforts to meet the needs for students who engage in problem behavior, with a major goal to eliminate the use of reactive measures, specifically restraints and seclusions. The pro side says that restraints should be conducted by trained individuals, but did you know that many times these trained staff are more likely to do restraints and holds instead of going off of the individual's behavior plan? That would cause less immediate effects from the Walker and Pinkelman article in 2018. Many behavior plans go off of least restrictive to none. Instead, we need to be teaching alternative behaviors and responding to these problem behaviors more appropriately. As you can see in visual 3, there is a questionnaire that was given to parents to complete. These questions showed that many parents did not know the reason why the types of restraints were being used. And it also shows that almost all of these children that showed any type of challenging behavior were put in restraints despite the fact that positive behavior support was recommended in their treatment plans. This questionnaire also shows that despite the many laws and bans of this type of punishment, this population is still vulnerable to this. It is easy to conduct a functional behavioral assessment to identify the function of the student's problem behavior. From here, you can give the student a replacement behavior or some new coping methods, along with training all staff, not only working with the client, but everyone in the center to non to least restrictive. There are safety care trainings that teach you the same way. That concludes my statement.
All right, and we are now nearing the end of our debate, and the pro team will have 4 minutes to summarize their points and make closing remarks.
The restraints and seclusion should be used when they are determined to be the least restrictive treatment to ensure that the individual receive their right to behavior treatment. Circling back to Code 2.09, we must consider the code of ethics when administering restraints to make sure that our clients are receiving the right to effective treatment. Evidence does support this right to effective treatment and that this is an effective treatment based on the articles and studies that both Lizette and I have shared today through the pro team supportive arguments. The positive effects of restraint are evidence-based to decrease both disruptive behaviors and self-injurious behaviors. It can also have a subsequent effect of increasing on-task behaviors and other positive behaviors. Furthermore, research shows that implementing restraints to decrease problem behaviors can decrease not only their frequency, but also the intensity of problem behaviors. So when you consider the very severe behaviors that can occur when self-injurious behaviors are occurring, the safety of the client must be considered, and that restraints can ensure safety of the client when they are implemented in a safe manner.
All right, now we will pass it off to the con team for their closing remarks.
All right. According to Shimmerman, he also states that techniques that can potentially prevent the use of restraints and seclusion should always be used first. If restraints are repeatedly being used to help minimize maladaptive behaviors, the current intervention is not effective and needs to be modified to decrease the use of restraints. And the study correlates of restraints use in an institutional population, a replication by Stormy et al. Concerns about restraints leading to injury and death continue to be expressed. In this study, participants that had been restrained for behavioral reasons had significantly higher anxiety, pervasive developmental disability, schizophrenia, stereotypy, elimination disorder, and impulse control disorder scores. You will now see a couple of visuals that include the demographic of the participants and the results. Here in Table 1, we see the gender, age, ethnicity, and level of mental retardation of the two groups. One group consists of clients who are restrained, and the second group consists of clients who are not restrained. In Table 2, the results of the two groups are displayed. The group that had been restrained had higher scores on the irritability, stereotypy, and hyperactivity scales. Implementation of least intrusive intervention and effective early interventions need to be a priority to help minimize the use of something as intrusive as restraints. Use of restraints raise ethical and practical concerns. Not only are they dangerous, but research has shown that they can function as a positive reinforcer for some clients and ultimately end up maintaining the behavior that was meant to be reduced. Putting the client's safety first should always be a priority, and the use of restraints and seclusion can be harmful and potentially result in injury, unknown psychological trauma, or worse, death. And that concludes my statement.
All right, and that's the end of the debate portion on the use of restraints and seclusion on individuals with developmental disabilities. And we will now begin the Q&A portion. The first question is, a lack of training is a potential issue for those who perform restraints. Are there any strategies or methods that can help improve training for administering restraints and or decrease the need for restraints?
So I will be speaking to answer this question. There actually is crisis prevention intervention trainings, also known as CPI trainings, that are available across the country. I've actually attended these trainings personally, so I can speak to the effectiveness of these trainings. These trainings teach individuals how to prevent behaviors using positive strategies, how to assess crisis situations, and how to weigh if the risk of the behavior outweighs the risk of a restraint. So if the child will be more safe if a restraint was put into place, or if just using those proactive strategies with behavior is the more safe decision in that moment. Individuals who take this training are taught not only these proactive strategies, but are also taught how to administer restraints. They're shown visuals, and the instructor will model how to administer restraints. And then there will actually be a practice portion where the individuals taking the course will get to physically practice administering the restraints on each other and be assessed through a physical test to see if they are administering these restraints properly and safely. And they must pass this physical test as well as a paper test to show that they truly understand these crisis prevention intervention strategies. And once they pass these, then they can be considered certified in crisis prevention intervention. And the certification only lasts for a couple of years, and then they must become recertified and retake the course or a refresher of the course every several years to ensure that they are continuing to implement restraint safely if they even have to determine that in that setting, a restraint is deemed the safe treatment.
All right, and now we will move on to the second question. The use of restraints and seclusion vary from setting to setting. For example, in Indiana, mechanical restraints are not recommended to be used for people in adult services. Is it ethical to use this as a way to address behavior if it is not something that can be used across various settings? What happens if a child has a mechanical restraint in one setting but then moves to a new setting where that type of restraint is not allowed?
All right, I will be discussing a pro perspective to answer this question. Mechanical restraints are used to address and manage violent and or self-injurious behaviors. Although very controversial, the use of mechanical restraints are used to prevent harm. Preventing harm is a core ethical principle of ABA, and I believe, on a personal note, that it is ethical to use mechanical restraints even if it cannot be used across varying settings, because each case is different, and every client is different, and every intervention has to be specific to that client. Mechanical restraints are necessary in some cases, but not all. For example, I actually had a client that I was working with and engaged in severe SIB behaviors, and her SIB was frequent headbanging and intensive headbanging. And from an RBT's perspective, you kind of have to know, and at some point, when to call for somebody to give you a restraint, because in our state, we weren't allowed, or I wasn't allowed, I'm not trained, to provide a restraint. So we had to call the BCBA to come over. But as a BCBA, at some point, you have to know if you're doing more harm than good, and when to draw that line of safety. Like, are you really benefiting? Is the client truly benefiting by letting them headbang, or is blocking enough to really keep them safe? And at some point, you have to know when to take that step to properly implement a restraint to keep them both safe and alive. And that concludes my statement.
All right, and now we will move on to the third question. Do you have any personal experience related to this topic that you would like to share?
I've had many personal experiences performing restraints for aggressive clients. And every time we would do a debriefing afterwards, which is very difficult to do so because you can see how traumatizing it is on the client along with the staff after everything was said and done. I have recently stumbled across a new intervention where you work on individuals' thoughts and recognizing when their body is changing, when different demands are given. So kind of like knowing when they're like super upset to angry because they don't want to do the work or the demands are too difficult for them. So an example of this would be you give the child a high demand that is aversive. Instead of going into escape and targeting the staff working with the client tells the staff that they don't want to do this, or they are upset that they have to do this and use their social rules of changing tasks or asking for a break. And the staff would then reinforce the client for telling them their feelings or using their correct social rule. And there is also a response cost involved that is individualized based on the client and their behaviors, along with opportunities to earn tallies where they can spend them at a marketplace that has items for the students to buy. And then they also get to take that reinforcement home. We have been doing this for about 4 months now with one of our clients, and we've seen the aggressive behavior decrease significantly. The duration of behavioral episodes have been a little bit longer, but they are less aggressive to no aggression at all. So it's actually pretty cool to see the client use some of their coping skills and their mindfulness that we've been working with them for the past 4 months, and they are essentially calming themselves down and not going into behavior. And then so that's why I think that sometimes restraints are not needed, and you can just find a new intervention for the client to decrease those behavioral episodes to a minimum.
Okay, that is the end of the Q&A portion and our debate as a whole. I will list now our references for the pro side right here, and the con are right here. All right. Thanks everyone for listening and following along. That is our debate.